I worry that, we'll be victims of new toy syndrome here, and somebody will have some sort of what they believe is a quick technical solution for, let's say, remote healthcare. These things are constantly being brought to market. But workforce resilience is something that takes years to build.
Hello, one and all, and welcome back to a new episode of The Rural Impact. I'm Michelle Rathman, and you know by now, I hope you do, that we are the podcast that works hard to connect the dots between policy and absolutely rural everything. Now, today, you're hearing this on January 15th. It kicks off an ongoing 2026 series focused on the $50 billion taxpayer investment in rural health transformation. It's called the RHTP, and it was born out of H.R. 1, which is the same law that mandates cuts of about almost $1 trillion from Medicaid over the course of the next several years. So I want you to be thinking about both of these as a part of this law, and it will be very important moving forward for this conversation. We're calling this series quite simply Tracking Transformation. And over the next 12 months, we will periodically introduce you to experts working on the ground in their own states. And we're going to be tracking their rural health transformation efforts. And we also want to follow the money, as they say, to help you and us, quite frankly, better understand what these dollars are doing to move the dial and improving access to healthcare and outcomes, while also addressing the countermeasures that stand to impede momentum where this is concerned. So in addition to this series, because we're not just going to be talking about rural health, although this is a very important subject at this time, we also have in the works episodes that explore policy as it relates to early childhood development and childcare in rural areas, transportation and mobility, which for many rural communities continues to represent roadblocks and speed bumps to economic opportunities. And on that note, we're going to explore, policies that impact rural economies, including the extent, and this is very important, the extent of how rural counties are managing the shifts coming at them from federal policies that reduce the amount of funding they receive. And as you might be reading some reports, leaving them with shortfalls and few options to make up for those, with the exception of potentially increasing local taxes, which is something that I don't foresee many folks being supportive of. So it's an ambitious year ahead of us. We are so grateful that you joined us in the passenger seat for this journey. You're not in the back seat. You're in the passenger seat with us right along with us. So thank you for that. Now, with all of that out of the way, let me tell you about today's guest. First, you are going to hear my conversation with Mr. Bob Atlas, a seasoned healthcare strategy and policy expert with Grace Creek Advisors. Now, we talked with Bob about an analysis he just released focused on the Rural Health Transformation Program. And then after that, and it's a really fascinating conversation with him, but after that, in a short break, we are elated to be joined by Kevin Bennett. And Kevin is the professor of family medicine at the University of South Carolina School of Medicine in Columbia, as well as the director of the South Carolina Center for Rural and Primary Healthcare. So we brought some people who you can definitely say are in the know in on this first kickoff of our series. So with all that said, thank you for your patience. It is now the time when I invite you to tune out that background noise. No doubt about it, it will be there when your time is over with me, and listen to my conversation with Bob Atlas and Kevin Bennett. Are you ready? I was born ready for this conversation, so let's go. Bob Atlas, welcome to the Rural Impact. We are so glad you could join us for this conversation for many reasons, because my goodness, what an eventful start to the new year we've had.
That's right.
All right, Bob.
A lot going on.
A lot going on where this is concerned. So as our listeners learned in the opening of this episode, and I teed it up in our last episode, we are going to be dedicating a number of our episodes this year on tracking transformation, specifically the Rural Health Transformation Program that, of course, most of us know was included in H.R. 1. I won't say the alternative name. And we invited you here because you have developed and released a really interesting analysis, very succinct, but yet very informative, focused on our RHTP, specifically detailing funding by state and so much more. So before we jump into those specifics, let's start with, which I loved that you did, with observations and questions. Okay. So that our listeners are clear, let's have you answer this question. Will these funds be used to offset estimated $900 billion in cuts to Medicaid? That's one of the questions you ask of the $50 billion or observations that the $50 billion will not offset the legislative estimated $900 billion cuts to Medicaid. Break that down for us.
Well, so the tax bill, the HR1, as we both like to call it, Congressional Budget Office estimated that the total 10-year loss to Medicaid would be over $900 billion. And Congress saw, at least some members of Congress saw this impacting states really adversely, and rural healthcare in particular. So a decision was made in the creation of the legislation to toss in this $50 billion of rural health funding. It is not directly meant to put a Band-Aid over the Medicaid cuts. It's supposed to transform rural health care. I mean, as I noted in my little piece, it only amounts to $140-something per rural resident. So it's not like it's going to deliver a lot of health care. It needs to be used in ways that can really leverage the funding so that you create a more durable and sustainable rural health system.
Yeah, we don't need a Band-Aid. We would need a tourniquet for that. I'm not a clinician, but I do know what hemorrhaging looks like. And, we talk about, in the paper that you wrote, you talk about $144 per rural resident per year. But let's be really clear. This money, this $50 billion in taxpayer funds. I mean, I really want our listeners to understand this is no gift. This is taxpayer dollars. There is somewhat of a formula. As we know, states have already received some of this money. But, you write that the RHTP focus on rural care is laudable, and I agree with that. I mean, anyone who's been in this industry, today I just read a piece. Today we're recording on the 8th of January. We drop on the 15th. Another Kansas hospital closed. And I wrote on my post on LinkedIn, like on the tombstone, it'll say we owe over $23 million in rent. So what can, clear it up for us. What can this money do and what it can't do? And then let's juxtapose that to confronting the urban safety net and why this is such a crucial point, because we have to connect these dots. That's what we do here.
Sure. So on the first point, I think the government was CMS, the Centers for Medicare and Medicaid Services, which is the agency tasked to deliver on this piece of legislation. They've made clear this money isn't simply there to pay the back rent on rural hospitals, because that's not a situation that's going to produce any leverage. Mm-hmm. It's on, many people would like it to be that way. So the money needs to be used. A lot of it's going to be used on technology, expansion, particularly on remote services. It's going to be used to build workforce resilience, both in terms of creating a pipeline of people who will work in rural settings and who will have the clinical skills and aptitudes to focus on primary and preventive care, because you're not going to see a lot of specialty care all of a sudden appear in rural settings. And then it's going to have to be used to bolster, some kinds of facilities, and to make it, we're going to need a layered system here where the people in the rural communities, will have remote, some limited emergency care, and then the ability to get to specialized care when they need it. Mm-hmm. So, transportation is also going to be important. And I don't frankly see a lot of focus on transportation in terms of one of the uses of this.
Right.
Expected uses
mobile
of this
units. I see mobile units, but we're going to be doing a series on rural mobility and transportation as well. So you made the connection between the challenges confronting the urban safety net. Why is this a crucial point? I have an idea, but I'm really curious your perspective.
Well, there are people who are disadvantaged in the rural communities, but there are also people who are disadvantaged in urban settings. And, inner city healthcare is also suffering from the standpoint of, bad reimbursement for the facilities that are there,
Mm-hmm.
and difficulty in keeping a strong healthcare workforce there. I mean, it's a different problem than the rural problem, but it's still a reality that, those hospitals and community health centers and others are going to be also suffering from this Medicaid depletion of funding.
Yeah, and other strains to community health centers. You bring up a great point, because one of the things that I've been thinking about a lot, Bob, is, we anticipate many more hospital closures. I think the math is like right there in front of us. It's not a prediction. I'm just being practical here. And as we just talked about the Kansas hospital, as we lose rural hospitals, people have to go somewhere, and they'll be pushed more into metropolitan areas. And so the strains on those systems, and then compounded by an influx of patients and complex medical needs because they've been unmet. It's difficult. All right. So let's talk about the calculations that show the bucket of taxpayer money. You said earlier about $144 per rural resident. Make no mistake, no one's going to see a check in their mailbox for each state over a 5-year this program. So a question you pose focuses on how such limited funding, and in reality, it is limited funding. It looks like a big windfall, but when you think about the totality of what's needed, what needs to happen in your estimation at the state level? Because I'm seeing a lot of people putting out ads for a rural health transformation program coordinator and so forth, to really move the dial on transformative health outcomes.
Man, that's a really challenging question. To start with, they're going to have to get some traction. I mean, this money is showing up. The states largely aren't ready for it. They're putting out solicitations not only for people, but for contractors to help administer these programs. So, and I suppose to the extent that there's good news, latitude, the federal government says that the money can be spent, doesn't have to be spent in this budget period, which the first budget period ends October 31st of this year. The clock is already ticking. You've got 12 months beyond October 31st to spend this year's allotment, and the same for the next 4 budget periods, which will be 12-month periods starting November 1st each of the next 4 years. So step one is just to get a rational, organized way of putting the money to good use.
Backfilling their plans, right, Bob? I mean, the plan, they had to apply. They had a very short window, 50-something days. And for me, it kind of feels that like the analogy of ready, fire, aim, and that they had to create the plans, and now they have to figure out a way to make their plans plausible and deployment.
Right.
And it just seemed to be less than ideal strategic direction. That's just me.
And that may explain some of why the allocation among states was not what you'd call obvious, because I think some states already had things in motion that they could say that fit the criteria for these applications. And so those states don't have to invent new programs. They have ongoing programs or programs that they would like to put more emphasis on. And so they, call it shovel ready projects, if you want to use the colloquial term. And other states were more flat footed. And so, one of the questions I have is, because there's some ambiguity in CMS's notice of funding opportunity. It sort of says this is a one-time opportunity to apply. So the question is what you applied for this past November going to stick for the next 5 years, or are you going to get a chance to ask for additional or different kinds of uses of the funding? Will the allocations change over the next several years, as I asked in my paper, either based on states' performance in deploying the funds or if states can apply to do new and different things. But to your point about getting this money, actively put to use, yes, it needs to be put out quickly and aggressively. We can talk about some technological solutions. I worry that, we'll be victims of new toy syndrome here, and somebody will have some sort of what they believe is a quick technical solution for, let's say, remote healthcare. These things are constantly being brought to market. But workforce resilience is something that takes years to build. Many of the states talk about building the pipeline for rural healthcare workers. Well, that starts in 7th grade. And so we need to see that investment happen immediately. And also funding for retention of people in the rural healthcare setting, because, it's challenging. And as the infrastructure crumbles, you need people to be supported in other ways so that they can stay there. If a hospital closes, there's still those people. They'd probably like not to have to move or be unemployed. So can we fund them with other kinds of supports other than the hospital building that just closed, for example?
Bob, you bring up some really interesting points, in particular about workforce, because that's making a lot of assumptions that the people, the individuals, they're going to be coming alongside. And I had a conversation with somebody yesterday about somebody that a lot of our listeners know, named Tony Pippa from Brookings Institute. He showcases this spaghetti chart of all of I call it a hot mess, of all of the rural programs and offices and so forth. And I really want to create a visual for kind of the competing or conflicting forces. So you talk about technology deployment and the new toys and so forth. At the same time, we've got policies that are kind of, curtailing the ability for rural communities to take advantage of grants for broadband, for example. So for these things to happen, these things have to happen too. We have to connect those dots. One of the things that you talk about is the fact that, CMS's allocation method for the $5 billion of 2026 discretionary funding included many factors, several quite subjective. And that gets a little sticky. So talk about that observation, if you please.
So in the notice of funding opportunity, they actually published, their criteria. 50% was what I'm calling objective, but you might say, why did they choose certain figures? That's like the absolute number of rural population in a state, or the percentage of population in rural areas, or the percentage of hospitals in a state that receive Medicare disproportionate share payments, Medicaid disproportionate share payments, which indicates a high uninsured and Medicaid patient load. So they use those, and that explains 50% of it. The other 50%, there were 16 different factors, each getting either 3.75% or 1.75% to add up to 50%. And that is based on what, the judgment there is. I'm not faulting their process. I think that they used experts, and they tried to be as objective as possible. And by having a lot of factors, you don't put excess weight on any one. That being said, you do have to wonder, how two of the states with the smallest land areas in the country got disproportionately higher amounts, when in fact, the area of a state in total square miles is one of the so-called objective factors, and it's worth 5%. So it's a little perplexing. It would be nice to see the feds reveal how they scored each state. I don't think that they will. Some states the states that didn't get so much might want to probe on that to see how they were judged. And, but maybe rather than fighting over what just happened, to prepare for the next round and see if there's opportunity for adjusting those allotments.
Mhm.
Again, that's been very vaguely stated as to whether the future opportunities will change.
Yes. Oh my gosh. And so what a great segue, because, I've been talking so much transformation. It really goes hand in hand with transparency. And so there's a lot of conversations that I'm having. I was on a call this week, which we'll talk about with our next guest, that talked about some of the skepticism, and rightfully so, because again, how this whole thing went down. But transparency has been something that everyone in this space can that I've talked to and agrees is critically important. And yet again, there's some skepticism there. So you asked the question, will CMS publish the details behind each state's award decision or higher awards based on application quality, so forth and so on? So, what's your message there? What?
Well, CMS and many of the agencies in this administration have been growing less and less transparent. And I'm going to try to avoid being overtly political here, but I don't expect there to be broad transparency any more than they've already been. I mean, at least they published the criteria ahead of time. And, so there are records, there are forms that were filled out by reviewers and so forth. So the records exist. So there can, ultimately there can be some accountability. I think that a lot of it, may have to be thought about as the states that assumed that they were going to just get a chunk of money didn't do a good job on submitting their proposals. I mean, look, half the money was given out equally among all the states. You could say, well, that's not fair in and of itself, but that's the way Congress wrote the bill. The other half of the money is this discretionary, and half of that half is supposedly, based on objective factors. The question is, were those objective factors that decided upon sensibly? Doesn't really matter. The awards are out, and they have to get to work putting it to use and make sure that it doesn't all get spent on administrative process consultants.
Where urban, this is something I had a conversation last week with someone who is really got a kind of a very upset, I should say, about the fact that they feel that urban hospitals are going to come out as winners here. So for example, we talk about remote healthcare, we'll bring in robotic surgery and so forth, but the economic piece of this goes back to a health system or an urban center. And so we'll be watching that as well. I have no evidence or any information about that factor, but I do think it's an important one to watch and a part of our responsibility to be transparent.
Yeah. And I can't argue that at all. And, urban health systems, in fact, in many states are keeping rural healthcare alive.
That's true.
They've taken over a lot of rural hospitals and made them into outposts that, maybe don't do inpatient care anymore, but they at least provide primary and emergency care in outlying communities where if those hospitals were on their own, they'd simply fold. So, but you're right. And what it appears CMS's intent here is to not just give the money to hospitals and health systems.
Yes.
States' proposals, in response to the way the notice of funding opportunity was worded, states are putting heavy emphasis on primary care, on local workforce, on mobile healthcare, as you noted, and things that aren't heavy on bricks and mortar. Mm-hmm. 75 or so years ago, we had a bricks and mortar program for the development of rural healthcare called the Hill-Burton program. And it was good for its time. But, if you look at that and you say, well, what's the current, 2025, 26 alternative to that? It is based on leveraging technology and By the same token, you've got people in rural communities they tend to be older. The people who are on both Medicare and Medicaid together, dual eligibles as they're called, are higher in rural communities. Nutrition is poorer. All those factors that I'm sure
all those not we call them now. We're supposed to call them, instead of social determinants, we're supposed to call them non-medical factors. And no matter what language you want to use, to your point, rural health transformation, making rural America healthy. I don't know where the again comes from, but making rural America healthy will require us to look at the really big picture and connect those dots. So my last question to you, Bob, because this is, again, I'm so glad that you could be here and provide us with your perspective. Everyone knows this podcast is about connecting the dots between policy, not politics, policy and rural quality of life. And with that, how our listeners can be more effective at their advocacy. One of the hopes I have is that more rural leaders, cross-sector of leaders, and then with their communities, whether it's faith-based, education-based, economic development-based, county leaders, city leaders, that they get in on this conversation because it does impact them. So what idea or tool, you've had a very long, successful career, not, because you've been around for a while talking about this. What strategy, tool, ideas can you offer to our listeners about why they should be paying attention to this issue if they're not in this field, or they, haven't really dug deep into it, and maybe something that you can share that they can take away and say, yeah, I'm going to have this conversation with the appropriate people. What say you on that point?
Well, if you're not paying attention, then somebody's going to take stuff away from you because, with budgets tightening, costs everywhere going up, somebody's grabbing for every dollar. And if you're not active, if you're not paying attention and being active, you're going to be a loser no matter what. What to do, and in rural healthcare, as we have already stipulated, is eroding as we speak. I saw that same piece about the Kansas hospital closing yesterday. What you do, number one is advocate with the state agencies that are responsible for deploying this money and make sure that they're going to be using it wisely with good input from the people who it's meant to serve. There's bound to be plenty of states that are still open to discussion on how, and not just how, we can say, well, technology or mobile healthcare. Well, where are they going to put it? Where in a given state is it going to go? So be advocating there. Also, many, it's early January. Many state legislatures are coming back into session. So make sure you get with your state legislators to have them either oversee what the agencies are doing or, help nudge the state agencies in certain directions. And then, for bigger picture and longer term, certainly talk to your U.S. senators. I focus on the senators more so than on the representatives that's for another discussion, but I think many people understand why. And make sure they understand. I think it was senators more so than House members who put this money into the budget bill and, or the tax bill. And, we need them to make sure that the uses are appropriate and that long term it's made sustainable. And, and frankly, I'll just put in a word for, since it's actively happening as we speak, the ACA subsidies, those affect people in rural communities disproportionately.
Yes.
And, that's not this money, but it's a large amount of other money that needs to be properly put out to use. Yeah.
I think, maybe you'll agree, maybe not. I think that this $50 billion rural health transformation program in many ways was kind of look over here and not over here. And we have to put these two together because they are absolutely 1000% connected to each other. Real quick, Bob, I want people to be able to, we're going to put the link to your website on our resource page, because if you are interested to know what your state was awarded and track that, you've got this great analysis. And I hope that you'll keeping us updated as you follow this progress, as are we.
All right. Well, thank you. And appreciate you having me on, and good luck with making some influence here.
We hope so. Oh my gosh. Thank you, Bob Atlas. And for our listeners, please do not go anywhere, because this conversation is not over. We'll be back just after a break. Stay tuned.
The Rural Impact is on the rise. Thousands of subscribers and listeners, hundreds of downloads per episode, a growing community of influencers united by a shared commitment to lifting rural communities. We focus on sound policies that improve quality of life for more than 60 million people who call rural America home. This is your invitation to be part of the rural movement, because your involvement can help shape real progress and lasting success. Explore our partnership opportunities and discover how we help expand your rural reach while sharing your rural impact. Visit theruralimpact.com to download our partner prospectus, or email partners@theruralimpact.com to schedule a time to talk with us. Are you ready? Let's go.
Hey, we're back. And as promised, this critically important conversation about the Rural Health Transformation Program continues with our next guest, Kevin Bennett, professor of family and preventative medicine at the University of South Carolina School of Medicine in Columbia. And also, if that weren't enough, the director of the South Carolina Center for Rural and Primary Health Care. Kevin, I've known you for a while. I'm so glad to have you here. Welcome to the Rural Impact. Thank you for your very valuable time today.
Absolutely. Glad to be here.
Well, as I said, things are busy. And anytime we're talking about rural health, I don't know, sometimes we get eye rolls to the back of our heads because there's just so much going on. And before the break, I was joined by, as our listeners heard, Bob Atlas, a seasoned healthcare strategy and policy expert with Grace Creek Advisors. And we talked with Bob about an analysis he just released focused on the RHTP program, Rural Health Transformation Program. A lot of people doing analysis on this, but specifically, we talked about the funding by state and discussed several of the observations and many of the looming questions that a lot of people I know have as well. But Kevin, you have been, I want to tell folks, as the past president of the National Rural Health Association, and all of your advocacy work, you are in a lot of rooms where conversations are happening. So I want our conversation in this series that we're doing to focus on a couple of things, and I'll just tick down that sheet and we'll get started. So I want to talk about strategic goals outlined in the notice of funding, the NOFO, as they say. For those who are not in the industry, they're probably not paying attention to what all that means. Right. Talk about some of the logistics about rolling out this massive program that was given just a matter of less than 60 days to put together. How distribution is going to work. And then from there, let's focus on using the funds for workforce, because I don't want to spoil it, but that is a prevailing conversation right now. Also, sustainable access to high quality rural healthcare, which is what we all want, improving prevention and chronic disease and so forth. But let's start with those strategic goals, Kevin, because there are 5 of them. And if you wouldn't mind, could you just walk us through and give us a snapshot of what, when states put in their applications, these are the things that they had to have in mind and make sure their answers were glaringly obvious that that's what they were talking about.
Right. And if you've read through them, they tag these very explicitly. There's one component around Make Rural America Healthy Again, which is a common theme in the administration. And this kind of has to do with like a lot of preventative type stuff. Nutrition, chronic disease management, screenings, but also healthy lifestyle was a big focus in this as far as the guidance goes and as far as the applications went as well. So that's one piece. Another piece is that sustainable access you mentioned, where this one I find the most interesting. And I thought the proposals that were submitted and awarded did some interesting things with this. And it's about how do you establish long-term points for care for rural communities. It did explicitly acknowledge, which I liked, in-person care is great as far as we can, but then how do you supplement that with primary or specialty care rather? Coordination, a lot of kind of referral systems, things like that. So this one seems like a more systemic type of focus area, which
and
that's
Kevin,
my
I want to interject on just the sustainable access. I've been talking to folks about how we put in one column, these goals and objectives, and in the other column, the roadblocks that are preventing us from
Right.
reaching that. So how do you provide sustainable access to care when obviously this program is not designed just for hospitals or clinics, but
Right.
when we are losing providers and we are losing facilities, bricks and mortar. So I just think that's something that we really need to be paying attention to, because you cannot have one without the other.
Yeah, for sure. And I think this one is interesting because I think it has a lot of potential to be transformative. What I've read in the proposals from the states, there's nothing earth-shattering in there. It's all the things we've talked about for years, closed loop referral systems, IT integration and interfaces so you can share data. Some of them had some things like shared purchasing, shared HR systems, those sorts of things. And it's interesting because I think it has the potential to bring these smaller rural providers, if they're not affiliated or owned by a system, to at least be brought into a community where they can interact more effectively and efficiently. Could reduce costs, especially the purchasing and HR shared agreements. If you're getting data when your patients go out of town and come back, you're able to treat them more effectively and possibly even get higher reimbursement because you're coding differently. So I think there's a lot of potential there to transform the flow of care through the system, kind of a hub spoke type of model. Some states explicitly are setting that up, a regionalization of care. So I think that has a lot of potential. I think on the backside of that could positively impact workforce because you're going to feel less isolated.
Which is the next kind of pillar,
Right.
if you will, right?
Yeah, you're going to feel less isolated. You have some resources. You have collegiality. You can care for your patients more effectively, which makes you more interested to work in these rural communities. Because a lot of folks want to. It's just they hit these barriers and they go elsewhere because they get burned out and frustrated and whatnot with those barriers. So I'm optimistic about that.
And the good news is so much of what you described is already happening. I mean, I have seen it. You look at the collaboratives and the cooperatives in different states and the coordination that's happening. It's happening. I suppose it just needs to be, funding is kind of a key factor here, is it not?
Yeah. And that's the key is can folks and states actually use this program to take what they're already doing, expand it, supercharge it, really break down all the barriers, get all the systems flowing. So by the end of the 5 years, it's a self-sustaining enterprise. That's the goal and the hope. And like I said, I have a lot of optimism about that piece.
Well, I want to sip from that cup because there are some days I find it really challenged to be optimistic. I've been in this industry for, over 30 years. It's been tough. So we know those are the 5. Let's just do real recap. Making rural America healthy again, sustainable access, workforce development, and then there's innovative care. Tech innovation, I get, but let's talk about innovative care. What are some of your thoughts about what you've seen in applications and what does that actually mean? Can you define that in some clear terms for us?
Clear, that's a good question. So I think the purpose and intent of that was for states to develop more innovative systems for payment, delivery, practice, those sorts of things. Really pushing the boundaries of, okay, if you really could do something out of the box, out of the norm, out of the mainstream, what would you do? And we did see several states talk about value-based purchasing and really ramping that up, which is innovative in a sense, but has been around a while.
Yes.
New in some states, though, and in some settings. So, that's fine. There were some that took a lot more aggressive stances. I believe Alaska, they have a really innovative payment model that they want to develop through this section. And there were a couple of other states, too. Probably, I think one in the Northeast, maybe in the Northwest. After you read 50 of them, they kind of blend together after a while.
Yeah.
But it's this one, I think, is the most difficult because, if you really want to be innovative and put your neck out there and push that envelope, you're going to have some failures and missteps. You're going to learn a ton from that and you can regroup and move forward and do it better. And that's the cost of innovation. the way this program is set up, it almost punishes that, because if you don't have great outcomes and you don't get things done within the time frame, there's a chance that you don't get to spend that money and you get less the next year. And that's kind of how it's written. So I feel like a lot of states were cautious and conservative in this approach because they didn't want to risk losing any funds. So
there's so many unpredictable factors. I mean,
Correct.
So many unpredictable factors. Yeah.
Right. I mean, and looking back, here we are in January. This passed in July of last year. So it's very quickly put together. NOFO quickly put out. Responses are very quick. It's never been done before. We have no idea how it's going to be run, how it's going to be responded with. The norms have not been established with it, so it's just uncertain territory. So I think there were a lot of conservative approaches to it.
Yeah, and rightfully so, because again, there's so many unanswered questions. So we'll kind of deal with what I have a saying, we deal with that which we are unable to or choose not to manage. So let's talk about the logistics, because I'm seeing, and as I said to our earlier guest, I'm seeing a lot of calls out there on LinkedIn and things like that saying, hey, we're looking for a rural health transformation coordinator. So applications are in, and now we're backfilling all this stuff. So strategy is not coming first. Strategy for implementation is coming next. So in logistics, where you're at in the state of South Carolina, maybe you can have an example. What are some of the logistics? Because it's not like, there's a lot of misinformation out there about, people who shouldn't be on Medicaid, or like checks are just coming right to their mailboxes, when actually we know that Medicaid payments go to those who are providing direct care. Right. So the money is not going in the hands of hospitals. It's not going in the hands of doctors. So let's talk about logistics. Where is it going? How is this being rolled out? If you could put that in a kind of pack it up in a nutshell for us. Yeah.
I mean, it's going out in 50 different ways, right? So, which is not
what a
helpful.
Coincidence.
Yeah.
50 states.
Right. Yeah. And again, it's one of those, this is an extremely unique program in a lot of ways, right? So every state gets $100 million over 5 years. Just that's the way the law is written. And then there's another 25 billion over those 5 years that's distributed based on the criteria from the program. And so that's when you see the states getting different amounts of money. South Carolina got just over 2 million. I think the range is in the 150s to the mid 200s as far as what the awards are for this first year. And so there's some inequality there. I know folks like Bob, your previous guest, have done analyses on the amount of money per rural person, which is fascinating. Yes. Huge range there as well.
Huge, yeah.
Like
I have a number in front of me, Kevin. Yeah, Michigan, individual states discretionary grants per 1,000 rural residents are broadly distributed. Lowest is 26,611 for Michigan, and the highest is 662,755 for Alaska. So I'll just say that.
Yeah, orders of magnitude difference, right?
Yes, right.
So there's a lot of differences across the states. If you read through them, you'll see there's a lot of differences in the approaches for how they're going to use the money as well. Some states are taking a very centralized approach. They're building offices, they're building infrastructures, they're hiring staff, those sorts of things. There's a Northeast state, I want to say Vermont, that's probably very wrong, that is setting up an actual Office of Rural Transformation that reports directly to the governor, which that's really interesting. So they in their application, they presented specific programs they're going to perform out of this office. And a lot of states did that. We're going to do the X, Y, and Z, and here's everything we're going to do. Other states, and my state is one of them, is taking a very different approach. We are hiring a program manager, I guess, so to speak, to run the program within our HHS with coordinators for each subsection. So they're going to have a team, but a vast majority of the funds are going to be sent out via subawards and consultants. So they're taking that distributed approach of there's a lot of folks in our state that are doing great work, running great programs. They're going to open an RFP for themselves for us to apply to say, this is what we're doing and give us money to do it. So, two very different approaches, and there's gradations in between, of course.
Yeah.
So I think it's going to be fascinating to see how all that plays out. I think there's advantages and disadvantages on both sides, right? And, I think South Carolina has the potential to send a lot of money out very quickly to groups that could spend it and do some really good things very quickly. I worry about how they're going to be able to manage and coordinate that across the programs, because that's a huge lift.
Yes.
With this team that they're hiring, very optimistic that that'll be effective. But, it kind of remains to be seen, and how that changes over the 5 years will be fascinating to watch.
Yeah.
So
I agree, Kevin. And that it's just, obviously it's a patchwork, all 50 states, they're shaped differently, and their programs are going to look different. And I think at the end of the day, the proof in the pudding, as they say, will be the data on what does transformation look like, which is why we're tracking it. Kevin, I want to talk to you a little bit about, you were a part of a panel discussion, and it was fascinating. We've had Sarah Jane Tribble on this podcast before. It was a really great conversation about, I think it was like decoding the RHTP. Yeah. And what I heard was a lot of emphasis and focus on workforce. And workforce, you can innovate all you want. You can use technology all you want. It will never take the place of me having a face-to-face with my provider, whether it's a mid-level or physician. So workforce is a big part of this. How will these funds be used to address all the challenges that we know we're facing with rural health workforce? It's tough to recruit. It's really hard to retain. And that has been something we've been talking about for decades.
Right. Yeah. I've been doing this for 30 years now, and, not to say nothing new under the sun, but we kind of know what sorts of things work generally. We tend to know what things don't work. And I think in these proposals, there was a lot of stuff that has been proven to work, pipeline programs and recruitment and incentive payments and those sorts of things. Training in place is a big factor. Rural residencies. I want to say Delaware is starting a medical school that they didn't have before. That's going to have a rural focus.
I read something like that too.
Yeah. So great. All of that is great. A lot of them also, though, I think are kind of decentered physicians a little bit, which is not terrible. It's kind of like decentering hospitals, the big expensive thing, physicians are expensive, hospitals are expensive. How can we increase the workforce that wraps around these services and extends them and provides great care and empowers the physician to maximize their time and their scope of work as well? So there were a lot of CHWs and doulas mentioned in these proposals, which I think is great, because then you can get to that social aspect of care and all of that. Connect them with physicians, connect them with mid-levels if that's what's there. So I think there's some good thinking around that. And with all of that, you're creeping back into that sustainable access piece of how do you set up a system where a CHW can communicate with different physicians and organizations and facilities and the pharmacy and, the food bank and WIC and all of that. And, that's what they're trained for. And that can be very effective. It's just developing that sustainable payment model for it is going to be key.
That's right, because these aren't volunteers. And for our listeners who don't know, the health speak, it is community health workers, and they are invaluable to the communities. And I look at, Kevin, I look at school nurse programs and things of that nature, where there's actual opportunity to have, interventions early. So again, I referenced this Decoding the Moment webinar, and you, along with your fellow panelists, were asked to describe in a word, which is hard to do, your thoughts about all of this. So in more than just a word, and again, as someone who's deeply involved with rural health for a long time, what are your thoughts, your concerns, your hopes? Because you use the word optimistic. Transformation takes time.
Sure.
And so some of your thoughts about, how far we're going to get in this first year, what are you hoping for?
Yeah, I think, gosh, that's a good question. I in that session, I used the word cautious. It felt like a lot of the proposals were cautious. I would say I'm cautiously optimistic about some of it, not all of it. There were some, I'm apprehensive about the technology catalyst pieces that are in the proposals. I fear that we will spend a lot of money on expensive, fancy technology that maybe not work and really doesn't get to the people that needs to get to. I'm also worried about supplanting in-person care in favor of devices, which is not a great thing. I feel like supplementing is great and can be very effective, but I don't want a device to replace a physician or a doula or a CHW.
And we have to be realistic because the technology is expensive and we have to make it accessible to patients. And we also know how many of you are what version of your iPhone are you on? I mean, technology changes all the time.
Right.
That's hardly sustainable.
Right. Yeah. And it's, and we still have places that, don't have cell service and don't have Wi-Fi. And you're going to give them an Apple Watch to do what with? Right. So I feel like we're kind of chipping away at these margins when we should be like, oh, how do we get them to see a person who can listen to them and address their concerns?
Kevin, this is kind of, you might not have the answer. I'm wondering, did you see, it makes me think about this. Did you see anything in the applications of investments in health literacy by chance?
Yes, I did see that a good bit.
Good.
Mostly, though, not health literacy in the traditional sense, but digital literacy. I saw that pop up a good bit. We have a group here in our state, Palmetto Care Connections, that's working on digital literacy with a housing community and an aging community. And they're teaching them how to use a mouse, which, that's where they're starting with. And, if you are not sure how to use a mouse, how are you going to log in for a telehealth visit? So
we take it for granted that everybody knows, that because, and it's just, so it's unfortunate and quite unfair that we do. I'm so glad to hear that. Okay. I have a closing question for you, Kevin, because I asked this of everybody. I mean, you read, I'm sure you have read, I have read, and I have heard that the RHTP represents, in quote, a pivotal moment for rural health systems nationwide. And at the same time, we know that you've been researching health disparities and rural policy for decades. Knowing what's ahead of us with massive cuts to Medicaid cannot be ignored in this equation. And other programs that affect outcomes. What do our listeners need to be prepared for? I know there's a big question, but from there as well, advocate for. I mean, we're all rural health advocates and rural advocates, if you will, to ensure that this pivotal moment actually transforms rural health and protects rural health resources, given the many other headwinds.
Yeah, that's a great question. And if I give me a couple hours, I could probably parse through all of it.
Yeah, exactly.
I think big picture is I would love for this moment and this funding to empower local rural communities to speak up, but to actually be heard. I think, as you well know, you go into these rural communities, they know what they need and they know how to probably do it. They just don't have the resources to get it done.
Right.
Or there's other regulatory, financial, et cetera, barriers to preventing that good care. There's a lot of wonderful models of care out in rural communities. Hopeful this can elevate a lot of those out of obscurity into impact, and really move that needle. I've been preaching here in South Carolina that rural healthcare innovation can lead the way in the state, as far as effectiveness, quality, value, and acceptability. I tire, and you have seen this too, of urban providers, urban systems, policymakers saying, here, rural, this is what you need to do to get better. This is how to do it. I'm here from the government. I'm here to help. And, it doesn't work because they don't understand the needs, the community, and what's going on. So I think that is something that I hope happens in this. I hope that we're able to, over time, take a look at everything that's happening and develop really great evidence base for models that are extremely effective. I would love to see, starting year 3, a narrowing of the type of proposals and programs that are out there, rejecting the ones that don't work anymore, everybody adopting ones that broadly seem to work, kind of a convergence, if you will, and how do we effectively integrate technology into that so that it meets the needs of the patients? Right. My youngest, she's 19, despises AI. Right. And,
interesting.
And there's an interesting generational divide there. There's a distrust and all of that. So her provider asked, hey, is it okay if I use this AI tool to take notes in the visit? And she was like, absolutely not. You cannot do that. So it's things like that where like, okay, there's some really great things about that tool. And those were all over these proposals as well. But how do we reflect patient perceptions, needs, preferences, and really get to a happy medium there of effectiveness?
Yeah.
It's a little bit of the Wild West.
Yeah. And we talk about meeting people where they are. So
Right.
if I could put out there, Kevin, is for all those who are making the decisions, for all the policymakers who are controlling the purse strings, Kara James, who was a guest, the remarkable Kara James from Grantmakers in Health said, simply walk the land. Go to the communities, understand the barriers that are in place. And this needs to be, I'm going to put it in positive terms, this is not a punitive endeavor. Accountability is not punitive. So walk the land, know what the communities need. And the only way you know that is not just listening to them, go there and see it for your darn self.
Yeah, you gotta connect and see it for yourself. And that's hard to do, but it's absolutely vital, or at least listen to those that are out there.
Well, a $50 billion investment, I would say, is worth the extra homework.
I would think so. There should be some travel funds in there for you to go see the world.
Absolutely. Oh, Kevin Bennett, I'm so grateful for your time and so grateful for your voice in all of this. We need rural voices like yours at the table. And so thank you for joining us. And any news you've got, we'd like to follow I tell folks, we're going to go on the road this year and we want to follow transformation happening. Yep. So again, Kevin, we thank you so much for joining us.
Yep. Thanks for having me.
Right. Great, everyone. So stick tight. Don't go anywhere because we've got some closing thoughts and I'll give you some updates about what's happening next. Stay tuned. We'll be right back on The Rural Impact. My thanks to Bob and to Kevin for joining me today for this really important conversation. And as I said, you're going to be hearing more about the Rural Health Transformation Program as we track this transformation multiple times throughout this year. And so we do want to hear from you on this subject, as a matter of fact. So if you've got insights, if you want to share with us what's happening in your state, if you are a part of this transformation, please, please, please reach out to us. Just go to our website, theruralimpact.com, and you will find ways to connect with us. And while you're there, please take just a few moments to subscribe. I am elated at all of our community that is growing. We are so grateful that you have subscribed to us, so that you can also get our e-blasts that come out to you from time to time right in your inbox. And of course, you can subscribe to us anywhere you like to listen to your podcast. And with that, I want to extend an invitation to you. If you have an interest to expand your rural reach, if you want to bring us out to your community, if you are having an event that's rural focused, whether it's transportation, education, healthcare, whatever it may be, we would love to be in the room where your rural impact is happening. I also want to make sure I give a really quick thanks to Bria Corsaro and Sarah Garvin for all their amazing work behind the scenes. And again, to all of you, I'm just going to say this every single time we close out the show. I am inviting you to take the best care of yourself and all those around you to the best of your ability. Again, I'm Michelle Rathman. This is The Rural Impact, and we will see you again soon.